Welcome to Health IQ. I'm Dr. Alan Siegel, your host. Today we have a very special guest, Dr. David Cuccia. Dr. Cuccia is a chiropractor and the inventor and founder of the ExtendTrack Elite. Welcome, Dr. Cuccia. Thanks for coming here.
Thanks for having me, Dr. Allen.
So tell us about this device that you've invented over 20, 30 years and what kind of brought about this invention.
Well, thanks for having me to your show. Appreciate being invited here. About 30 years ago, I don't look that old, that experienced. I was confronted with a patient who was bent at a 30-degree angle, sciatica down her right leg. She was a nurse. She had hospital traction. She had medicine, medical drugs. She was disabled. And she happened to be related to my sister's husband.
Okay.
And so she came in, we referred in for some chiropractic care, which only gave palliative care. Didn't do anything to help her disc condition. She had 3 herniated discs.
Okay, so she had herniated discs.
And it was causing pressure on the nerve root, that's correct.
Right.
And it was shooting down the right leg. And she had the very common antalgia, where some patients or some people who are watching this might relate to very easily when they, as you know as a doctor.
Well, tell them what is antalgia. Demonstrate so people understand what that is.
Antalgia is when you have back pain or leg pain, and the spine shifts, and it moves the patient away from their pain.
Right. And I think anyone watching that has had back problems can understand that position.
Yeah, they look in the mirror and they see their hip here and their shoulders there.
Yeah.
And it's the body's wisdom to move the spine out of pain. And so, 30 years ago it was a no-no to think of putting a patient into extension, which is bending the spine backwards, in a backward position, backwards. And we had done every adjustment that was possible. That's a manipulation of the spine. We had done physical therapy, physical therapeutics, ultrasound, diathermy. It was useless. She was still bent at a 30-degree angle. She was in pain. And I don't like to fail on anything I do.
Right.
And that's what led me in this quest at the Holy Grail. Now, the doctor in Canada who has now a machine 30 years later says there's no miracles, but this is the closest thing to it.
Well,
Usually he's a physiatrist, medical doctor using it in Montreal. Wonderful healing doctor. Works in an amputation hospital.
So you're motivated by failure, essentially. You wanted to help your patients.
So I wasn't going to lose this patient. Right. I wasn't going to lose only because of, not because I didn't want to lose economically. I didn't want to fail. Believe it or not, doctors, as you know, they really want to help their patients.
Sure.
And this doctor here was failing.
Right.
So I said, you know what? I got to separate those vertebrae as quickly as I can and as forcefully as I can without hurting the patient. So I basically put my back against her back. I picked her up in extension, backwards. All of the text and the literature and the evidence-based are all the flexion, knees up, pillows under the knees and all this. Here I'm doing a completely opposite concept. I'm going to pick her up and dynamically lift her, let the legs drop, and put her in extension, bend that spine backwards.
So the basic concept was extension. That's what drove you to...
Basic concept was ExtendTrack, and therefore, as soon as I put her down from that bending backward position with a combination of traction and dynamic lifting, she came down, all of a sudden she was moving her leg, and instead of being 30-degree lifting like a boat taking on water to the side, she was standing straight.
Because that biomechanical maneuver essentially released pressure probably on her nerves.
And we realize now from studies now that I'm sure you've seen also that based on the work of McKenzie, Dr. McKenzie in New Zealand,
protocol,
right?
Sure,
protocol,
yeah, he incorporates a lot of extension.
Almost concomitantly with my findings, is that when you bend backwards in a backward position, and that's what's used now currently for some exercises to help bring a disc that's herniated usually towards the back because the patient's lifting something up, and the disc collapses in the front, shoots the nucleus, the soft center of the disc backward against the outer core, and it pushes backwards. So here you're lifting, creating a space, closing the back, and driving that extruded disc material to a forward direction towards the umbilicus.
Okay, so you're helping actually move the disc material back into place to some degree.
We're shifting, using the body mechanics to shift it, that's correct.
And you mentioned,
with her, she had completely no pain. She was out of pain.
Just
practically with the first maneuver.
Right.
I had 4 months
and this was a manual maneuver, but I think if I'm
for 2 years.
Yeah, Because after a while, doing this, manually can be very taxing on the doctor.
Especially when you go into a woman's house, do a house call, and she's 300 pounds, it's the middle of summer, she's in bed, she can't get out of bed.
Yeah, well then...
And then you put her on her back, and you're struggling like this.
Then both of you will need the Extentrac machine.
Which I did later on.
Right, yeah. So then you decided to develop more of an automated system that is the Extentrac. And how is that different from traction or spinal decompression exactly?
Well, spinal decompression is really a new concept that's been out, and it's really describes the phenomenon that happens inside the disc to a body's response to a longitudinal long axis pull. Now, the work of Ramos and Martin out of the Rio Grande Hospital with the VAX-D, they put an intradiscal catheter in there, and they showed that there was a precipitous drop in the disc pressure. Now, how that relates to healing, we're not sure. But the concept that applies to any kind of long axis stretching, no matter what device you use, you're going to be dropping that intrainternal disc pressure. And when you do so, you create a negative pressure, and they call it a decompression of structures that are under compression. Most of the weight of the body falls through L4.
Like a vacuum effect? Is that the best way to describe this? We have a spine. Yeah, we have a spine. Let's demonstrate.
I see it over
and
here
show.
in front of my eye.
This way you can show our viewers.
L4 and L5 is where the weight of the body falls through L4 and L5 and on the discs, the L4 disc and the L5 disc.
Okay.
Now, all of the structures in the spine, including the disc, are pain sensitive. And they're impregnated with thousands and thousands of filaments and nerves. Even the cartilage in between the facet joints filled with nerves. And there's connections between the major nerve trunks that exit between the vertebrae.
So any pressure on those nerve structures would cause pain,
Standing, working, flexing, where the disc pushes back. It can push out that disc. Here's an example of the disc being pushed out. It can strike the nerve. Yeah. Here's the nerve.
And you can see that disc, it moves, so it shows that they can herniate in various ways in various sides and anterior and posterior.
Now, if I may say, in the terms of Sharon, had I bent her forward, I would compress the front of the disc and push that disc out more.
Right, if it was more anterior based.
Yes.
Yeah, okay.
So here I bent her backwards and applied simultaneous distractive forces to decompress, lower the internal pressure, and that disc gets sucked back in as you're elongating the structures and removing pressures on all of the joints that are pain sensitive and pain generating, all the pain receptors.
And what's interesting, even as you're moving the spine around, there's a three-dimensional component to the way you're moving the spine and the way our spines move.
Right.
So you're talking about long axis traction.
That's exactly correct. And so your treatment should be. The spine is three-dimensional, and so should your treatment. So in the case of some patients with the Extentrac, the doctor should first analyze. It's not just the machine, it's the protocol analysis goes with the machine. Yeah. And it's based upon evidence-based research. Some patients, based upon their MRI, may need flexion to drive the disc in the right direction, away from the nerve root or from itself. Other patients respond, like Sharon, need bending backwards. Extension. Yeah. Right. And so you do a provocative testing with the patient before you treat the patient.
So you may have the patient bend forward or bend backwards, bend to their sides.
Exactly.
What causes the pain? Where is the pain coming from? What direction causes the pain? And the direction would help you dictate how to treat.
And you do the opposite from the pain-producing direction. Right. So you're actually going to mimic that antalgia that the patient comes in. So in the acute, recent onset patient with severe back pain, leg pain, and a spine that's twisted like this, you don't seek you can't pull them straight, first of all. If you put them on a traditional, you asked what's the difference between Extentrac and traditional traction or decompression.
Yeah.
The Extentrac is 3D. It's three-dimensional.
Three-dimensional.
Where you can position that patient.
As our spine is, like we mentioned. Yeah.
So instead of pulling the patient, every patient comes in the same way, everyone's different. Instead of pulling in the same way, each patient is put into that position that mimics the pain relief that you've heard chiropractors say, innate intelligence.
Right, our body tells us which way to lean because we want to get away from pain.
Correct, and you observe the patient from seeing visually.
Right.
And then the MRI results. You put all this together and you say, you know what? We'll correct the chronic problems secondary. Let's get the patient out of pain as quick as we can. Quickest way to do it is to mimic the patient's pain relieving position. If we don't see any obvious changes on MRI, things from the patient from examination Then we go to our evidence-based knowledge of the literature, what's available in the literature, what positions for that age group of patient. Is there degenerative changes in the spine? Is there stenosis?
Yeah, there's a lot of factors that go into how to treat them. And so the ExtenTrack therapeutic device, so I understand, I think we're going to take a look at this in a little bit, there's multiple protocols. It's not just every patient, regardless of condition, gets the same treatment. People will get...
It's a very important point, if I may amplify what you're saying. A patient who was on ExtenTrack said he had gone under some sessions on a linear table, posed linearly, straight, without three-dimensional positioning first, prior to the application of distractive forces, the pulling forces. And basically, there's no clinical decision made. It's lay down and let's hope it works.
Right, because they're not modifying it based on the condition. It's just the same treatment for every patient.
It's not medicine.
Yeah, it doesn't make sense, because if you equivocate that to a surgeon, no surgeon would go in and always perform exactly the same procedure if the condition's different on different patients. So
Absolutely.
It doesn't make sense. So the ability to have multiple protocols.
And that's what's important the very first, second, third, fourth visit. If the doctor doesn't position that patient into the antalgia position that the patient presents, or based on the evidence-based and the patient's MRIs, and makes changes to the position of the patient platform that the patient lays on and the spine conforms to, and you begin the axial gentle distractive forces, you can actually drive a disc into a nerve root.
Yeah, so you have
and injure the patient.
Yeah, which would make them worse,
it's
obviously. We don't want to do that.
You're not going to get the results that you would get what we see with ExtenTrack. And I'm happy to say that.
Well, that's a good point you bring up, because patients, they're in pain, and we've both seen this in our careers, and they don't want to be even touched sometimes. How do we get them to get into a subtle distractive position, gravity, sometimes just gravity. How do we use gravity, and have you incorporated that subtle use of gravity into these protocols? Because a full distraction may scare people. They're not ready for that yet. So
their spine's not ready for it, that's correct.
And their body's not ready. So what can we do?
So there's intermediary steps before you just take everybody and treat them like this subacute. Subacute means you've got 50% correction. They've gone to, pain is reduced 50%. They have function, neurological function is improved. So you don't treat every patient as if they're subacute. When the patient comes in and they have full fulminating pain. I had a patient this week who came in to see me, who wears a security guard in the hospital. He had such swelling around his L5 nerve root that they thought it might have even been a tumor. And the first thing that I said is, did they give you any anti-inflammatories? And even though I practice a drugless healing art, it doesn't mean I don't recognize the benefit of proper medical
sure. You need to integrate
pharmacology.
All modes of healing sometimes.
So the first thing I said, you got to get an anti-inflammatory, you're too inflamed. And then we began gentle gravitational, using the patient's natural body weight and three-dimensional positioning. Right. And the first 2 or 3 times, take it very easy. You don't put every patient on their back or on their stomach. Right. And that's the flexibility of ExtenTrack, because 50% of the patients will get well on their stomach, 50% will get well on their back. Right. And then 50% will get better axially, 50% will get better three-dimensionally. So you have the versatility to mix and match and to change your treatment based upon the patient's presentation and changing an evolution of his symptoms. Right. So now within 8 to 10 visits, the patient's
and the protocol may
out
change.
Of pain.
And the protocols could change.
Exactly the point.
Yeah. So, all right. So we have some video here of this device. I think it's an outstanding device. I've never seen anything like it, quite honestly. And the multiple purpose and multiple therapeutic procedures that can be performed on one device is quite unique. So let's take a look at this, and we're going to describe this to our viewers as we're watching it. So this is the ExtenTrack Elite. This is the latest and greatest model. I guess 30 years in the making. It's transformed.
It's a 5th generation.
5th generation technology. So as
thousands of patients later,
medical devices continue to improve.
Multiple countries now.
And that actually happens to be myself, and we're going to do a demonstration. So you'll see, we put up on a patient here. The patient setup is gentle. It's quick. It's easy. Everyone needs to be relaxed. If you want to describe a little bit what's going on
here. Well, here we're rotating the patient back, and we're showing intermediate steps in the acute patient, the patient who's in sudden pain, onset of pain, we're using natural body weight and three-dimensional positioning.
There's
we're
the
just
gravitational protocol there that we were discussing. That's a very gentle stretch of the spine with very, very little stress on the body.
And they're not having to lay down, which sometimes is too painful for the patient.
Right.
And notice, doctor, you're positioning that patient away from his pain,
Right. So
which is removing the nerve root away from the disc.
Right. The antalgic positioning that we spoke about.
And then you begin to put movement into the spine.
Yeah. So as the patient's relaxing and you take pressure off of their nerve root, then you can distract a little bit. And just by bending people 5-10 degrees in one position, they may be like, I feel better there. I'm like, good, we'll leave you there.
Exactly. And you can do that as a part of the protocol.
Yeah. So I see a lot of versatility in this treatment, and I think, like we said, is the ability to treat patients in multiple positions with multiple protocols is quite unique, actually.
And I may add that it is direct spinal treatment. You are working on the spine. It's not as if someone comes in with low back pain and goes on an exercise bicycle for their hamstrings. We're really targeting in the treatment the specific disc level with all these three-dimensional positioning.
Describe the monitor over there. Is this an automated process or manual process or both?
You can do both with it, which is the wonderful thing about this versatile device, therapeutic device, is that you can even have patient interaction in the subacute cases after they've improved.
So there's some self-treatment on this as well. So after the patient's gotten used to it and understands what they can tolerate and what they should be doing.
And after they're out of their acute pain, their severe pain, they can start doing it,
Okay.
But you can do automated cycles or manual cycles, but what's nice about it is that you can be hands-on. So you can not only position the patient theoretically, with your hands on the patient's spine, if you apply 25 pounds of distractive force to decompress the spine, you can feel the tissue response of the patient with your hands, with your touching.
Yeah, tactile.
And you can feel the separation of the spinous processes, part of this joint. As you're stretching, you can actually feel.
So you're manually palpating and feeling the joint
stabilizing,
separate. Right.
And you're localizing exactly where you want the distractive force applied to which level, whether it's an L4 disc or an L5 disc.
Okay.
And you can feel the lack of movement, and you can encourage the movement in that area through mobilization, through a range of motion.
Right. Which is it's a very unique process because not only
the best physical therapy around.
It's automated, it's manual, it's hands-on.
Best chiropractic.
And if you want to do soft tissue work, the patient's in a very now here we see a little animation of a disc.
The disc bulged out, protruding.
Which is interesting. You have a protruding disc here, and then it'll show some of the activity of what happens when a nerve is inflamed, and that would be like a sciatic lesion, some kind of
mechanical pressure on the disc, right?
Sure.
Moving away from the pain.
Right, now you're moving away, so you're taking pressure away from that side or that whatever that leg was. And interesting to note is that sometimes people may have pain down one leg, and if they move into that same side, they have less pain, and sometimes when they move away, they have less pain. So there's various presentations that a patient may have in terms of where their disc is and where their pain is, and what's going to relieve that pain.
Correct.
So that's what's very unique. So that's a nice animation
the hydration,
of a disc.
the blue water coming in, fluid coming in.
Right. So you're rehydrating the disc.
As you're lowering the pressure inside the disc, you're also causing a imbibation, a suction of fluid back into the disc in the surrounding synovial tissues to hydrate and to bring oxygen and sulfur and electrolytes back into the disc so it can heal. So it goes from an anaerobic condition, which can't ever heal, a slow healing, to an aerobic condition, which life needs to heal, and that's what Extentrac does, and it localizes it purposely.
Now, what type of practitioners can use this device, and where are you seeing this on a national and international level?
I'm a chiropractor, but this has been developed by jointly by spinal specialists with input over many years. And when I was in Lebanese Medical University, I was asked by a spine surgeon, you're a chiropractor, and this is the chiropractic device. I said it may have been developed partly by a chiropractor.
Right.
But I just flew back from Russia, where we're in a major rehabilitation hospital, and 3 neurosurgeons were just trained to use it for 5 days.
Right.
And so a wide spectrum of practitioners can use it. It's not profession driven. It's a tool.
It's a medical device.
It's a therapeutic device.
Exactly. So in terms of
it applies the principle, if I may say, it applies the principles that are well known.
Absolutely. Well, in terms of surgery versus epidurals versus physical therapy, where does this fit into the whole treatment modality? When should a patient be seeking this type of treatment?
That's a great question.
Yeah.
There's a place for all of that, of course. We'd like to say that this should be tried first.
As a non-invasive type of therapy.
Correct.
Right. And then.
And we know we've all had stories of people who've had surgical failure. Epidurals have failed.
Sure.
Stenosis have failed.
Chiropractic has failed.
Chiropractic has failed. Physical therapy has failed.
Right. And the back is a very unique concept. I tell patients,
complex
you don't
structure.
have the flu. Okay, you're not going to feel better in 5 days. That's not what you have here. This is a much more complex problem,
Yes.
and it's a
They've
much
had
more,
it for 30 years developing.
Exactly.
And they have a very little space in the spine left. They have degeneration, and they have no hypertrophy of the facet joints, and is crowding the spinal cord.
So that was a very nice demonstration. I think viewers got a sense of the treatment, and I think that that young lady looked very comfortable. I think comfort is a big factor in any type of modality or any treatment. People are concerned about surgery or needles or this is minimally invasive, hands-on, therapeutic. So I think it should be something that should be sought out for someone, especially if they're having chronic and or acute problems. Is this only for chronic or acute, or a combination of both? I mean,
well, patients come in and they have had, you get a number of patients that come right off, referred right in with an acute case. But some patients, for comorbidity reasons, co-disease, diabetes, age, heart-related problems, other treatment failures they've had, they want to try something new and different.
Sure.
And this makes sense to them. And I can certainly tell you, clinical-wise, whether it's Korea or Russia or Texas or California or
hey, you told me about a patient in Korea, but before the show, what was going on there? You had some.
Well, actually, I had a very unusual experience in Korea where we went to some training. I did some advanced training in the Korean hospital there. We're in 5 major spine centers in Korea, one major one in Seoul, and the physical therapists are really enjoying the versatility of the device. We went to visit another facility for some advanced training down in the south in Hongik Hospital, and the engineer that had accompanied me on a super highway in Korea. We've done wonderful things in that country, and the Koreans have done wonderful things with the resources that U.S. has provided, and their ingenuity and their hard work too.
Sure.
And I was in a super highway on a Hyundai, and my engineer falls asleep at the wheel.
Oh.
And I'm acutely awake,
Yeah.
and I grab his wheel, and I tap him lightly on the cheek, and I wake him up. So that was miracle number 2. Sharon lifting her up 30 years ago,
Right.
curing her, getting the principle of Extentrac, and the other miracle of not being being driven into a wall in Korea.
Korea, okay.
But one of the most biggest thrills to me is seeing other practitioners around the world beginning to embrace the technology, because they understand that.
Yeah, what's the difference between like international and the U.S. in terms of embracing different types of medical devices
I
and
think
new devices like this?
Our thrust has seemed to gravitate overseas, because I think there's a greater understanding of natural healing and the body's respect for the body's processes to heal itself, the innate ability to heal itself. Great in the United States too, but you don't drive down the street and you see people doing Tai Chi in the parks here every minute.
Sure.
You're driving anywhere in Seoul, and there's people doing Tai Chi and
different level of awareness,
Shin
self-awareness,
and,
and self-healing,
and I think also, with respect to the wonderful physicians and chiropractors and physical therapists that are here, the motivated individuals, God bless them. But I think there's too much emphasis on material gain in the U.S.
Sure.
And I think our society has become detached, and I think it carries over to treatment care, where now people may say, should I make an investment of over $100,000 in an Extentrac Elite?
So
over 200,000. Over 200,000.
And the patients always want to know his insurance coverage.
Whatever the model they get or the price difference would be, depending upon which country they're in. But what's critical is they care to be in the best equipment, and the practitioner is impassioned
to utilize this type of
utilize the best equipment, whether it's my equipment or somebody else's equipment. And relationships are better, and everything is not based upon insurance reimbursement. Patients are willing to pay sometimes,
Yeah,
even
when
if the
people have
insurance
had
company
pain,
stops paying.
Pain motivates you to do a lot of things,
Yes,
especially if you had
yes.
failed treatments, and that's
So the
you
guy
probably helped a lot of people that have had failed treatments, that haven't worked in traditional means.
So would somebody in the U.S. pay upwards of hundreds of thousands of dollars for an extent track? Yes, but the motivation is greater
For the
to
healing
purchase it
effect.
because they seem to have a stronger desire, more connection with the people. I don't know what it is. Here it seems care is driven by reimbursement for a procedure, so and it's based on a time code. So if I can put a rubber band between a patient's legs with back pain, have them stretch in their legs, and I can charge a fee for that.
But without having a device like this, sometimes you're
But
not
it's
going
not
to get...
targeting the spine.
Right.
Here's an example. I had an acute patient that came into me recently, Alan, and Dr. Allen, and the medical doctor took this patient in acute pain, severe pain, and decided she's going to stretch his hamstrings. And she takes his leg straight and pulls it all the way up, something that might have even snapped the sciatic nerve, because we know it telescopes 2 inches
Yes.
out of the neural foramen as the leg is raised up, and it pulls. The leg is up, which is a straight leg raise test.
Yeah, it's an orthopedic test that we use.
Telescope's two inches. That's the danger of manipulation under anesthesia.
Yes.
That the patient's not going to say stop, and on anesthesia you're raising the leg up. So that's why those practitioners perform under anesthesia have to be well trained.
Sure.
In order to do that. So she takes this patient's leg, starts stretching it, and inflaming the nerve even worse. Okay. So with a patient like that, you begin very slowly, you treat very slowly, and within 10, 20 treatments, the patient is asymptomatic, has his life back, and when healing comes from the inside out,
right, and the muscles start to relax and everything.
And you haven't destabilized the spine through premature surgical intervention.
Sure.
That's admitting there's cases when that's necessary too.
Absolutely.
But this should be tried first.
Yeah. But it seems like it would be a great type of device or treatment modality that any patient with some chronic and or acute lower back pain, and there's many of those patients out there, to try this type of modality before they kind of go through the circle without getting success.
To amplify that statement you just made, I had a new patient that came in yesterday. I read his MRI. Stenosis, disc herniation, spondylolisthesis.
So
these are all conditions the most serious yet common causes in the 30-plus group.
Chronic spinal issues.
Chronic spinal, that long term, more than 6 months, that plague people.
Yeah.
And so the object of the extent track and the procedures is to create space.
Right.
That's the light bulb that went off in my head when we want to know why it works. What are we doing that makes it work? And we know that by the combination of manual therapy with mechanical advantage offered by powered stretching at select angles, our object is to pull away the ligaments, whether it's a disc or a ligamentum flavum, which surrounds the spinal canal and forms part of the cup that have collapsed and is putting pressure on the nerve roots. So it's to increase space, to open up the joint. And so with this patient, he has these things. And, do you want to tell the patient that some of the results you're having on a personal level are 80% or greater? So can you tell it to him? You can tell it to him. Everyone's different.
The knowledge factor is got to be very important too, to be trained and to use a therapeutic device. This is like going through an advanced training and having an advanced knowledge of.
Every practitioner that uses the machine around the world is and will be trained and certified by myself, who's the most experienced in using it.
Yes.
Now,
30-plus years.
Let's get back to that patient.
Well, before we get back to the
surgeon, wait a minute. I got to tell you this. The surgeon wants to operate on him as a first alternative.
Without trying.
I don't believe that.
Right. Well, sometimes hopefully we get to the patients before they get information that shouldn't occur.
And I got to say this. Another consulting surgeon said, try physical therapy first. but the patient already tried physical therapy.
Right. So there's
They've had.
right. So there is a need for this device.
So this is why physical therapists are adopting the use of Extentric or find the utility in it.
Well, look,
because it gives
I can
them
see you're
mechanical
very,
advantage.
very passionate about this, and this is such a wonderful
We
device.
do it to help people.
I know, and the device over 30 years of development is quite unique and quite extraordinary, and I really do appreciate your time, and I look forward to you treating successfully many people.
Thank you
Okay,
very,
so
very
thank you.
much for having me.
And thank you for watching, and we're hoping to keep you healthy and well. Thank you very much. Bye-bye.